So now we have Prof. Ong just arrived, and I think Prof. Ong, you should try to see whether you can share screen or not, Prof.
You allow me to share screen first lah. I cannot share screen. You never allow.
Yeah. Hey, Amit, allow Prof. Ong to share screen, please.
Done. All done.
Done. Oh yeah, then we can see you. Okay. Shall I introduce you first? Okay. We are very familiar with Professor Dr. Ong lah. Ong Ting Ek. And he is a professor in the surgery department in UC Malaya and also head of the urology unit. And one thing good about Prof. Ong is that one of his special interests is prostate cancer. Of course, that is very important because not many urologists in Malaysia who are really expert on prostate cancer. So he is one of our rare talent that can look after us. And of course, Prof. Ong is also, I understand, is also VP of the Urological Association that also work together with us. And they organize many conferences, professional conferences, in which we, PACSM participate and so on. So, of course, Prof. Ong, all through the years, has been very supportive to our PCSM support group meetings. And because of him and a few of his colleagues, we are very proud that when we have support group meetings there, we have record attendance. Once we have 90 people attending a support group meeting, and Prof. Ong changed a meeting room to the lecture hall. Just imagine, 90 people cannot sit, overflow. I think in the lecture hall, the meeting room can house about 50 people. Anyway, Prof. Ong is our favorite speaker. Why? Because you'll find out he is very both entertaining and always give us interested and give us full attention. In fact, I told my wife, Prof. Ong is speaking. He said, when Prof. Ong speaks, can you call me and I'll come in? So I'm going to call my wife. Okay, ladies and gentlemen, put your hands together. Professor Ong. Prof. Ong, all yours.
All right. Okay, thanks, Kwan Seng. Thanks, everybody. Thanks for turning up at Saturday afternoon. I will share screen first. Bagi saya check dulu. Share screen. Yep, you should. I'm sharing screen now. You should be seeing my screen. Yeah, you can see a screen here saying on recurrence of prostate cancer. You can see that, I presume.
Yeah, we are good.
Okay. Thanks a lot. So Kwan Seng give a lot of time. There's a bit long. Takut people tidur halfway. So we will try to settle this like about an hour lah, instead of 1.5 hour. So two part. One part, this one is on the Kwan Seng give this topic. So we learn about recurrence of prostate cancer. So the aim is everyone here who turn up today, now got 112 there, you will be expert lah. By this afternoon, you can give people a lecture on this lah. So that is the purpose of what we are doing today. Okay, so let me go back. And then after that, there will be a Q&A. Thank you for submitting the question. So thank you for tabulating it. I will answer them accordingly. Okay, let's go. Yep. So on recurrence of prostate cancer. Okay.
Catch the photo.
Can okay. Recurrence. You can take picture. Okay, you want to record also can. No problem. The host can press record if you want to. No issue.
Okay, good.
And that So recurrence, coming back, it is like America lah. The disease come down, then then the disease come back again. So like having a recurrence, every country, Malaysia, Europe, all like flattening the curve. But America have an increasing incidence, something like a recurrence for them lah. So they kena like that Okay. So as for prostate cancer, actually they are kind of the roadmap. You see the roadmap. A person normally they start here no cancer no cancer. Then they might develop some precancerous lesion. These are all very upstream, you know, all these are upstream. Then they develop localized significant cancer. Then if you don't treat, then it become locally advanced, it come out a bit, the kind of thing, you know. And after that, you know, if you leave it alone, then they become metastatic, you know, that we move on to the further downstream. So when we talk about recurrence, we don't talk about this early upstream one. We also don't talk about those very much downstream one, you know, those are different things. We are talking something in the middle here, talking a bit somewhere in the middle here. Those who have localized disease, you know, so it applies to this particular group of patients. You know, so we normally aim these two stages. Potentially we can cure them one, you know, meaning get rid of the cancer, you know, totally like kick it out, you know, settle it, you know. Then how do we do that now? Two-way, mainly two-way now. Surgery lah, whichever kind of method you do, surgery. Next one is radiotherapy, you know, different form of radiotherapy. So these two definitive treatment. So you potentially we can really, you know, cure the patient. This one we can cure the patient. Wow, this is the, you know, this is surgery, yeah, whichever way. And then the radiotherapy, yeah, whichever way, yeah. So you aim to cure the disease, you know, really flatten the curve, you know, get it out of the way. Okay, just like what the American presidents say lah, magically it all disappear overnight, you know, and you won't see it anymore. Yeah, he loved to say that, and he still believes that. I think, yeah, one day it will just disappear in a few weeks' time. Yeah. Well, however, on monitoring, you know, if the PSA remain low, then it's fine. Normally, the easy way lah. Most of us will say that we just monitor with PSA. I think worldwide it's the same. Everybody monitor like that. If after all this treatment, then the PSA start coming up, you know, then we get to start to worry lah. Maybe instead of flattening the curve, maybe we like America, you know, the curve come up again. That's where recurrence come in. That's where the story of recurrence come in, you know. So apply to these two groups. Initially treated, you know, thing is okay. Apa pula jadi, then the PSA come up, you know. So something must be not right. So we want to see why the PSA is rising, you know, where the disease is now. Yeah. So now what? You know, if that happened to this group of patients who have treatment, surgery, or radiotherapy, and the PSA come up, you know, now what do we do? So that is a whole story about all these things. The whole story about this thing. Okay, on recurrence, after surgery, you know, we monitor PSA. PSA supposed to be undetectable one, you know, undetectable one, zero, you know. So if the PSA become detectable more than 0.1 or what, depend on the lab lah. 4 to 8 weeks after surgery. Initially, after surgery, there will be some detectable level one, you know, first 4 weeks, 8 weeks, because the half-life PSA between 3 to 5 days like that. So maybe after 1 month, 2 months, you can still detect some PSA. But after 8 weeks or so, we shouldn't detect any PSA lah. So the PSA should be like undetectable. So if the PSA is detectable, you know, then maybe, you know, it's recurrence, the PSA recurrence, you know. So that's how it is, if you have surgery. Yeah. However, if someone who instead of surgery have radiotherapy to the prostate, your radiotherapy to the prostate, even though you're cured, the PSA cannot be 0.1, especially when they are having the, you know, the hormone injection. Cannot. Also, there will be some PSA level one, you know, for 1 year, 2 year like that. So for those patients who have radiotherapy, to define recurrence, generally agree if the PSA have increased by more than 2, above the nadir. Nadir is the lowest PSA achieved by the patient. If the lowest level achieved by the patient is, say, 0.5, say 0.5. So if the PSA on monitoring is 1, it's fine, no problem. 1.5, okay, you know. Only is it beyond like 2.5, then maybe, there is a PSA recurrence. That's how they define recurrence after radiotherapy. As we know, after radiotherapy, the prostate still there one. There's still some tissue there one. So there is a difference between the definition between the two. So it's all by the PSA test that we detect recurrence. Okay. So rising PSA after treatment, So the main question is, if the PSA come up, where is the prostate cancer now? Where is it now? So no, people don't panic first one, PSA rise up, recurrence, They don't rush into, say, give what medicine, do what surgery, do what extra thing. They don't think about that first one. The doctor, the urologist, oncologist, what they think in their mind, they will find out, mana itu PSA come from? Where the PSA come from? That's what people think about. So the number one job is not to rush in and panic and treat it, is to find out where is this PSA come out and where potentially the cancer could be. So that's the next step. Where it potentially could be. Whether the cancer is still localized, still hanging around the prostate, meaning the first round bombing did not kill everyone. Still got some surviving cancer cell in the prostate or near the prostate bed there. Or the prostate has somehow moved beyond the primary area, beyond the prostate or the prostate bed, and have gone to some other place in the lymph node, in the bone, and has become metastatic. So the most important is find out where these cells are, or if there is anything there, whether localized in the prostate or have moved on. So that is the most important. Before we talk on treat this, treat that, or the high power thing, before we talk about that, we must know where they come from. Okay, where they come from. That's the key thing. So this one, I will highlight to you the key thing. This is the NCCN guideline. I think worldwide, a lot of people use that from America one, National Comprehensive Cancer Network. So all these you can download, basically free from online. They also got a patient guide one, but I just highlight this is the latest version. Latest version in May one. They keep updating like 4 times a year one. So here, look at here. What investigation the American will recommend if the PSA come up after treatment? Bone imaging, PSA doubling time, they will calculate this calculation. Bone scan they will do, chest CT, abdominal pelvic CT or MRI, or a PET scan. You see the American PET scan lying a bit one, They will choline PET lah, flucyclovine PET, that kind of thing. Not the usual famous PET that we know of. Later we come to that. That's in official American guideline, The famous PSMA PET. It's not there one. Not there one. It's not that fantastically popular in America yet one. You see? Yeah, but the whole world using it. They have to be special, right? Yeah, just like the president. So this one, prostate bed biopsy, if they think that there's something in the prostate, they can biopsy again. Okay, so with that, they will know whether the prostate cancer, or if there is any, is inside the prostate or it has spread. So the imaging is the most important to start with. So that is after surgery. So if the prostate bed, meaning the operation after doing, when the scan, MRI, whatever, still got some tissue left there, then maybe you can biopsy that tissue. Seldom done, this one seldom done one, because those tissue, if ever left over, will be very, very small. This after surgery. This is the European one. European one lying a bit, you see? The European one, this is the latest one, this year one. It said it's a PSA recurrence after surgery. You see? The European one got PSMA PET one. So people more advanced one, they somehow, Americans so-called more advanced, somehow a bit slow in adopting this. Europe, Australia, even in Malaysia, we are adopting this quite fast one, So the European guidelines say, you should do a PSMA PET if the PSA is more than 0.2, because above 0.2, there is good chance that it can, the PSMA PET can detect where the cancer is. And then if the PSMA PET not available, then only you do the choline PET and fluoxetine PET and all that kind of thing. So meaning if available, you do the PSMA PET. That is a European recommendation. And normally we follow the European. That's after surgery. Okay. If you done all the tests, okay, and they have found no metastasis, meaning it didn't spread anywhere, yeah, everything is, probably just left in the prostate bed, meaning, very likely after operation, some cell left at the prostate area, around that area. If that is the case, we can do external beam radiotherapy with some ADT. So that is what they call the salvage radiotherapy. That can be done. Malaysia people know how to do it. All the oncologists know how to do it. So after surgery, PSA come out. You do the scan, it didn't spread anywhere. Everything is just in the prostatic bed. Then you can do salvage radiotherapy. Quite a standard thing. All the Malaysian urologists, oncologists will recommend that. However, if the scan, any scan, a bone scan, PET scan, whatever, show that is metastasis, the disease has moved to the bone or lymph node after surgery, then the treatment is for metastatic prostate cancer. That we won't delve with today. Meaning, they upon scanning found that it has spread, then we follow whatever treatment that is for stage 4 metastatic disease, which is still very much able to control. Okay, what the Europeans said like that, offer salvage radiotherapy, SRT, 66 gray of salvage radiotherapy after surgery. After surgery, PSA come up, after scanning, didn't spread anywhere. Okay, we do salvage therapy. We bomb the prostate area one more round. So that is the plan. That's the European recommend that as well. Okay, just now what we mentioned are all after surgery. For localized disease. What happened if people, the patient decided earlier on, said no surgery one. They say, they want radiotherapy for localized disease or locally advanced disease with ADT and all. So if they after radiotherapy, okay, so the European guideline, said, you can use MRI to look at the prostate, see whether there's any disease, still there in the prostate or not. Okay. Then it said you use PSMA PET also to see whether the disease has spread anywhere else in the body. So that's again looking at where the cancer is. The extra thing here is you can do an MRI of the prostate because the prostate is still there. After radiotherapy, prostate is still there. You look at the prostate, see if there's any more cancer inside the prostate. Potentially can still biopsy those areas. If the PSMA PET or the other imaging show that there is no spread of the disease elsewhere. Okay, after radiotherapy, there we go. If all the scans, say PSMA, PET scan, and all that, show that there is a metastatic disease, then we treat as metastatic disease. That is stage 4 disease. If they found, they already to bone, to lymph node, then we treat as such. However, if there's no spread anywhere, and then the biopsy of the prostate, show that there's cancer, meaning the cancer is still inside the prostate, but no distant mass. You see the negative for distant mass. Everything is still, meaning the first round bombing by the radiotherapy did not kill all the cancer cell in the prostate. So what should we do? So this is a difficult area, very difficult. After surgery, disease is not at other place, but it's still inside the prostate. This is a big challenge. No easy answer one. When you look at, there's so many options there, meaning people do not know what's best to do it. I think they give you option A, B, C, D, E, F, G, up to Z. Meaning people do not know what's the best treatment. So here, for some people, some just observe. Some can do surgery again, radical prostatectomy, that is salvage radical prostatectomy, which is supposed to be difficult, very difficult, yeah, or all this brachytherapy, cryotherapy, HIFU, high intensity focused ultrasound, that kind of thing. So that is the difficult part. Yeah. So need a lot of discussion with the patient, and depend on what is available, the expertise is available to deal with that, meaning the disease is still in the prostate. Yeah. Okay, what happened? You scan, you didn't show anything negative for distant mets, but the prostate biopsy also negative, meaning don't know where the cancer is. You biopsy prostate, also didn't see anything, nothing, but PSA is coming up. So what people do is that you can observe, just see how the thing is, or you can start ADT. That's what the American recommendation, to start ADT. Yeah. So that's how it is. Yeah, that's in summary. So that's American earlier. Now we go to the European recommendation. Yeah, how the European recommend. Okay, salvage radiotherapy can be done. Salvage radical prostatectomy, salvage RP radical prostatectomy, only in experience center lah. Seldom done one. Even in experience center also, they are also not that fantastically keen on that. Yeah. Next one, you can offer, salvage HIFU therapy, cryoablation, salvage brachy, all that. That is in a clinical trial setting. So meaning all these things are still at the moment still not like standard treatment one, Okay. So next, the key point in summary, the key point here is. So in patients with localized disease, it applies, the concept applies to patients with localized disease who have underwent definitive therapy, okay, but the PSA is rising on follow-up, yeah, supposed to be cured, yeah, but PSA coming up. So we need to do imaging to decide whether the remnant cancer is still localized to the prostate, or yes, spread elsewhere and has become metastasis. Yeah. So then we manage accordingly. Depend on whether the disease is still in the prostate or the disease has spread elsewhere. Then only we discuss the treatment. So that is I think that is a summary of the whole story about recurrence. The outline. So with that, we can hopefully flatten the curve and all that. We can flatten the curve and bring it down to some, normalcy. So, but basically all based on evidence all things that we do, we cannot, like the guy in front, just talk and say whatever he wants on, Everything must be follow the guy behind who wear the mask and just, make progress based on clinical evidence that we have. So thank you for that. Yeah. So that is actually done for the outline on the question of recurrence after prostate cancer. That basically covers it. That basically covers the outline. So that's done. So I will change the deck to the question deck, a very long question deck. We can pass it on to the Guan Xing and anyone who have any comment or question to ask. Yeah.
Okay. Well, I think maybe on Prof Ong's talk, we can spend about 5 or 10 minutes. Anybody have a question? You can just wave your hand.
Can raise your hand.
And then after that, we go to the question that was submitted. I think, Prof Ong, Mr. Lim Po Hua has put in a view graph all the questions one by one, and then we put onto the screen. Maybe then from there we can comment on it. Is it okay? The question that was submitted.
Is it the deck that you sent to me or what?
Yeah,
I think so. Yeah,
that's the same one.
Don't worry. That one, no need. That one I prepare already. This is
you prepare already. Okay, that's very good. Very good. Okay.
You can see this one, right? University Malaya Medical Center. This one, right? I prepare already.
You prepare already.
Okay, never mind. What I will do is that if you have no urgent question here, I will move on. We
move on. Okay,
we move on. Okay,
yes.
So now is the Q&A already. Basically, all it's a very heavy slide deck, quite a heavy deck because the questions are all very tough, very tough question. Okay, so you all can see this one, So, okay. All right, so that is the question. So I use the same deck. Okay. Some question are more detailed, some less, and it depends. Yeah. So I will pretend that you're asking. Okay, let's go. Q&A. Okay, this is your timetable here. Okay, question. Question. It's like going for exam for me, I would say, all these questions. Very tough. I need to study and go and find answer and all that. But very good, Then I think I know more today as compared to yesterday before I look at the question. So that's very good. It's a learning thing, Every time I give a talk like that or thing, I become smarter, I think. Yeah. Okay, question number 1. Is it possible for us, Prostate Cancer Society Malaysia member, to purchase drug from UMMC pharmacy without being a registered patient in UMMC? So that's a question. They don't have the blue card, don't have the registration number. Can I go and buy from the pharmacy? The answer is you need to register so you cannot So whatever way there must be you must be a patient with the 8-digit registration number with the
thank you, very good.
Yeah. Okay. So you have to do that. Yeah. Okay. Now they are quite in that sense. I think probably one of the few hospital 100% digitized one. That hospital is fantastic. In terms of digitization, 100% one. And their IT system, they didn't buy from a vendor one, It's all homemade one, made in the hospital. The IT people, they're super smart people there. Yeah. Okay. Next one. Okay, this one. Tough. This one tough. What is the recommended gram, of coffee intake per day? Or in terms of teaspoon size, Oh, you how lah this one So never mind but good I stuck I like coffee but I never think how many grams. I never think like that so it's good. So I start thinking but I cannot call Starbucks. I do not know anybody from Starbucks, so no point I ask Starbucks. So where I ask got answer. I could find someone middle of the night. I dig someone up from their sleep and ask them last night. I asked Miss Rosanna. Rosanna is our dietitian, from UMSC. She's very nice lady, very nice lady, Rosanna. So I asked Rosanna quickly, late evening, check all the things for me, and then send me a lot of information. So in summary, it is I think quite consistently should get it is that 3 cups of coffee daily, apparently quite good. 3 cups of coffee daily reduces prostate cancer risk by half, by whatever magnitude. So I think generally a few things say 3 cups, but some cup big, some cup small, so very difficult. Some cup kecil, some cup big. I'm not a coffee expert. Got different kind of combination of coffee, how much milk inside and all that kind of thing. So one of the information she give is like that lah. Now all the study they said investigator define more than 3 cups of drinking 90 gram, yeah, which is convert to ounce about 3.17 ounces. That's about that. And then comparison with the Starbucks here, you see the short is already 8 ounces. Yeah, tall is 12, grande is 16. So cukup lah. I think if you if you drink 1 Starbucks a day, I think that already enough. That's good. So of course, that's just roughly say like that. Of course, anything in excess also no good. I think you drink 10 cups a day also probably not so good. You probably go to the toilet very often from the caffeine, irritation to the bladder. Yeah. So that's that for coffee. Yeah, I like coffee. Yeah, I think most of you would like some form of coffee as well. Yeah. Okay. Question number 3. This one interesting. 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 Look at this one. As a lifetime exposure of radiation, to the person, is about 100 milli sievert. That's the unit used for radiation exposure. 100, meaning this one actually, meaning the one person whole lifetime, if you don't do anything and just sit at your home, go to work, come back, that kind of thing, you probably receive 100 milli sievert kind of radiation. So the question is, do you think patients should be keeping a log on their exposure? Meaning every time you do a scan, you log. Whether you should do that? Because you see, PET CT, all those PET scan plus CT, already 25, 25 milli or sievert, meaning they should not take more than 4 tests, in the whole lifetime. After 4 PET scan, that's it. Thank you. You pay money, so I won't scan for you. So is that true? Is that true? Yeah. Is that true? Yeah. Okay. So with that, for that, after I disturb Rosanna, I asked another person. So Dr. Nasri of radiology, he is the boss in charge of all the nuclear scan, all the PET scan, and then okay. So he helped me. So in summary, he said there's no one. That is his answer. The head of nuclear medicine and PET scan. He said there's no upper limit for radiation. We will give as low dose as reasonably applicable. Meaning you don't have to like log it on one. The doctor would not like over prescribe scan and all that kind of thing. And when a scan is indicated, to monitor or to decide on treatment, it has to be done. It has to be done. And the harm of radiation also varies between different age group. So radiation, you think is a CT scan, the radiation from CT scan, PET scan, you think is more harmful for older people or younger people? The answer is it's more harmful for younger people. So the younger people better don't get so many scans. But they are growing, they are growing, the cell dividing more faster and all that kind of thing. And then they got many more years to live on planet Earth. So the young people, we try to reduce the scanning. But as the older people, so the risk of radiation is slightly less one for all the scan and all that. So that is basically the main story to that. So it's okay one. Of course, you don't order lah. So this is a radiation chart just for fun. Okay. So you see, natural radiation we all exposed to per year. We get 2 already. Every year you walk in, walk out, walk in, walk out. Go to hospital. Go to Prostate Cancer Society, Malaysia meeting, come back, whole year like that, you get 2 million of sievert. Then if you're air crew, you are in the Japan Airline, ANA, whatever, you fly from New York to Tokyo, the polar route, annually, they get 9, So it's not the easy job to be pilot and air hostess. 9 already per year, So 10 years they get 90 already, if they work in that route, So they are still fine, they are okay. A full body CT 10. Even the doctor who help you do the scan, they also at risk. So like Nasri, all these people, they're at risk one, So they every 5 years they wear a tag one. All the radiologists like Nasri, they wear a blue tag one. They will document how much radiation they receive. So they cannot be more than certain limit, like 5 years, cannot be more than 100 or so ever. Because every day they go to work, they are exposed to the environment near those CT scan, near those PET scan, whatever, So they are the one who are a very high risk one. So they wear tag, they wear that gown and all that kind of thing. And then they got more liberal holiday one. They got more holiday than us one. Because my job is just talk. Very low risk of radiation. Okay. Question number 4. Yeah, number 4. Here. During this COVID, in order to keep the glucose at the healthy level, important, patients who are practicing plant-based diet will have a tough time as eating salad is not recommended as it's not cooked. Okay, that's fine. Yeah, but I think nobody get COVID-19 from eating salad. I think nobody. Okay, just all rumors. Okay. Are there easier plant-based protein that you recommend? You know, this one I look at the moment I look, I know I do not know the answer. But never mind. Again, I call for help. Rosanna again. Rosanna help. Rosanna help. Okay, Rosanna help, and the answer is there we go. Yeah. I think this one quite important. Plant-based protein. Nuts, seeds, soya base like tofu, turmoil, beans, pulses, legumes like lentils, chickpeas, black beans, and all that. Yeah, so that's helpful. Yeah, those are plant protein that you can have. Yeah, so that's how it is. And I know you know what is pulses. Pulses normally we think of the heartbeat, the pulses. So apa itu pulses? I also searched the apa pulses. Pulses are all those bean, that is low in fat one. These are the bean that is good lah. These are we always eat. I think kacang putih got all these things. No wonder people who eat kacang putih very healthy lah. Okay, that's the first set question. First set. Next one. Next patient. We will next question. I hide the name lah. I just blank out the name. So okay, after robotic surgery to remove prostate September last year, that's about 9 months ago, PSA still high. PSA still high. PSA still high. If the PSA never come to zero and the PSA is still there, there's a technical term to that. It's called PSA persistence lah. But it meaning there's still some tissue there. Either they are prostate tissue healthy one or they are cancerous. That one need to be identified lah. Okay, but we go on. Shall I go on hormone treatment or do orchidectomy? Meaning you do hormone treatment or not? Or I just leave it, I just do PSA every 3 months. Don't kacau, don't bother. Tengok dulu. I'm 75 years old. 75 years old. I cannot do radiotherapy. Cannot do radiotherapy due to extensive diverticulitis. Diverticulitis is a colon problem. Appreciate guidance. So thanks for the question. So I think the first thing we don't have to panic first lah. Don't have to panic. Because actually surgery done is good. The main bulk of the disease gone already. So what we need to do, like I said just now, we must go and find some imaging lah. See where the thing is. Where this PSA come from. If the prostate cancer is after like PSMA PET whatsoever, it's still in the prostate, then you can have radiotherapy, right? And then short-term androgen ADT. Don't have to have long-term ADT. So of course, if you have spread, then only say if the scan show it's spread to bone, then only you go for hormone therapy or orchidectomy and so on. So I think no need to jump into any treatment unless you have the scan to find where the enemy is. Just find out where the problem is. No need to rush for any treatment, whether the disease is still in the prostate or it has escaped. So that's the key. I'm sure your doctor, your urologist or oncologist will be able to advise you on that. Okay, we move on. So follow lecture. This is the same thing that what I mentioned in the lecture. So I said follow lecture recommendation. Okay, this one. Look at it. This one tough. This one tough. This one, the ongoing patch. Patch is an acronym for study. Patch study, meaning people use estrogen patch. Just patch on it instead of makan estrogen. The estrogen kind of patch, they patch it on there. So estrogen get absorbed to the body lah. But must shave hair apparently lah. Banyak hair cannot the hair block the estrogen. This is promoted by UK people one, the estrogen patch by a guy called Paul Abram in London one. The Paul Abram is a good friend of Professor Azad. I met him a few times also before when I was in London many years ago. So we go on. He said patch tests involve estrogen patches, to replace LH, RH agonist injection or the Lucrin or the Eligard, all that kind of thing. So no need inject all that kind of thing. You use the estrogen patch. Got its own benefit, like got its own benefit. Do you think this is a feasible option? If yes, can this estrogen patch be used for IADT, meaning intermittent ADT? Would you agree that men on ADT have low estrogen, which leads to osteoporosis, and the patch will rectify the issue? Lastly, should men on ADT test their estrogen? So in summary, this patch study, it is still recruiting one, or is still recruiting. No result yet one. No result yet one. So that's the simple answer to that. So with that, we call that still investigational. Still investigational on the trial basis. So no definitive answer one. People want to use that, can, you don't want to use, okay, it doesn't matter. I think the trial is going to finish by next year, 2021. So if actually you want to see any trial, there's a trick one, you just Google it to the trial registry. You just say trial registry. It will show you to the trial registry, which is in America one, trial.gov, because all the clinical trial, the proper one must be registered to a registry one. The most popular one will be the American one. So you will show all the data there, whether the trial is still going on, or the trial has stopped, no people want to join, stop, or the trial is totally rubbish one. It's all there one. So and normally we don't test for estrogen level. That's the simple answer to that. So at the moment, the patch one is a fantastic idea, but the general recommendation is still not there yet. So we wait now. Maybe we got good news in 2 or 3 years time. Okay, next one. Thanks for this is next question. Okay, can prostate cancer be cured? We love that. We love that. And then the next question is, how do you classify as cancer free? I mean, we go to second question first. How do you call it cancer free? Actually nobody knows one. You cannot count every cell in the body and say, oh, everyone free. Do a census. Like Banji Negara, now census Malaysia going to start, you can't Banji every cell one, they cut no way one. So basically, how do you declare someone cancer free is by the imaging, whatever imaging we have, bone scan, CT scan, PSMA PET. If all the scan turn out negative, then we say, okay, for this time, you are cancer free. Can prostate cancer be cured? Of course, there can be one. Of course, can be one. Of course, can be one. Of course, can be cured, especially those in the earlier stages. So always there's hope one. Always, the hope will be there one. Even for stage 4, even the spread everywhere. That's more other one. I think there's still hope for cure one. This is not bluffing. I'm not doing a Donald Trump on all of you, but it is possible, because you look at all the trial, they give some treatment here, there, whatever. There's a percentage of patients who somehow they are fine one, after 5, the fellow still there one. They always hope one. I think hope itself, it carries us a long way. Okay. The next question, next one. What time now? Oh, 3:40.
Still a lot of time, yeah.
Yeah, but we don't want to drag too long. Tired. Mouth dry.
45 minutes only, yeah.
Don't worry. Yeah. We see how much we can go. Don't overwhelm too much information also. Because got cake cutting, right? Later you will send the cake to us by Grab. Is it correct? Thank everyone. Yes. I wait for the Grab cake. Okay. Cake, serious note. This is good. You see, from what I understand, yellow fever vaccine is taken when you visit certain part of Africa, may compromise your immune system. If a COVID-19 vaccine is found, will it have the same effect on compromising immune system? As there is no long-term data on the side effect of such vaccine, is it advisable to delay vaccination as long as possible? This one, actually, the answer quite simple one, because we are thinking too far ahead already, this one, because the thing is that there's no vaccine one. Because there's no vaccine, as we know, as far as this COVID-19 is concerned. Of course, there are many leading groups, the most prominent leading group, like people ask you, the most prominent will be from the Oxford group, the Oxford group. So they are the forefront for in terms of vaccine development for COVID-19, followed by the China group. There's one group in China also. So these are the leading vaccine development group. Of course, there are many other centers they are developing it. Is like an arm race now, But whether it's not there yet, so that's a fact. It's not there yet. And it's quite unlikely to be available by the end of the year, pretty unlikely. And if it's available, how effective it is, we do not know, And how long and how many jab of vaccine you need to have for COVID-19, nobody knows. Whether the immunity will stay or what, nobody knows. So there's many question mark on this thing. So we don't worry about that. You simply can't worry about that because nobody knows the answer. No one knows the answer. And that is the main point. And also, all these things that we heard about vaccine, not good, whatever, must take it with a pinch of salt, or 1 kilogram of salt, All these are a lot of fake news circulating around. The most famous, as you know, a lot of American or overseas parent don't allow the kid to have vaccination. They say you vaccinate, and then then the kid develop autism. Autism. They always say like that. This anti-vacciner, there are such thing. You watch a documentary, even in Netflix, you got. This is actually a fake news one. It actually started like 10 years ago or 10 plus years ago when there's a very reputable journal, I think Lancet or somewhere. It published a paper by a UK researcher saying, they study already if this a group of young people have this measles vaccine or whatsoever, later they got high risk of getting autism. It all started from there one. Actually, after people have investigated and found that those baseless one, that paper has already been withdrawn, cancelled out already, fake news, out. But the problem is the demon has been let off already, you see. So everybody keep believing that. Now you go and say, that paper that many years ago, the orang putih say one, that one fake news. The people don't want to believe you anymore. The moment some fake news come out, people just believe. Just like there are quite a significant people in the Western world still believe that the world is flat one, The world is not round one. Got people believe that. I think about 6% of Americans believe that the world is flat one. Okay, so we must pursue fact. It's difficult. Okay, we move on. Yep. Okay. For men having RT radiotherapy and 24-month or Dukrine, normally they give ADT for radiotherapy, and then have recurrence after 4 years. After 4 years, pretty good, After 4 years, meaning quite good response. Where bridge 2, will it be good to add abiraterone if ADT is required? So this thing again, the thing is, quite, I will do a direct response. I go back. This one, I won't type anything. I just give the direct response. I won't type things there. Okay, direct response. So if you have radiotherapy and a very good response for 4 years, and now the PSA coming up, so it is the same theme like what the mini lecture we have just now. You must see where the cancer is, whether it's still in the prostate or it has spread anywhere. Then only we talk about treatment. Then only we talk about treatment. So we don't have to worry about abiraterone whatsoever, ADT whatsoever. First thing first, we find out where the cancer is, and then we take it from there. So that is the thing. Next one. Is there a best timing to do genomic tests, upon diagnosis or wait till recurrent? This is a big question, A lot of people will, you go to America and all the overseas talk, when all the world leader talk until they got nothing to talk about, then they start talk about this thing. So basically, there are certain tests, whether these cancers are basal cell, whatever, epithelial cell, whatever, certain genomic ATM mutation of this gene will be responding to that and that. So it's a kind of a lot of study being done on that. To keep it simple, the test is quite expensive one, cost a few thousand. 5,000, yeah. But the implication of it until now, not definitive one, not definitive one, not definitive. So that is a simple answer to that lah. But of course, if those people at the moment the advanced disease, we want to start on those olaparib, niraparib, all those things, all the PARP inhibitor. Normally they advise to get a genomic test. So that is the thing. This one I checked with Maniza yesterday also. Maniza said it's not generally done one. Even in anywhere or the top center, mainly is investigational too. In America, a lot of commercial one, whatever advertised in America also we have to be quite careful. A lot of center, the main objective is to be famous and earn money one, so we have to be careful about that. Okay. Men after stopping ADT have low testosterone. ADT is all the hormone jam. Instead of letting the T come out by itself, you exercise, normalize. Sometimes you come back to normal. Sometimes you don't. So is it advisable to have T injection, testosterone injection? There are many ways to get testosterone. Can oral tablet, can have injection, but the most effective one are the injection one. It's available in Malaysia one. There's one brand that we use quite frequently. One jab can tahan 3 months one. The kind of testosterone replacement. So whether can or not, the simple answer is that at the moment, people think it's pretty harmless. If there's no more cancer, meaning it's cured already, meaning oh yeah, you have surgery, radiotherapy, everything, all cancer gone already after 2 years or so, no what you mean that there is no recurrences, and then you can't find cancer anywhere. The current belief is you want to inject is fine. That is a current belief in July 2020. It is okay, but people are very reluctant, quite cautious about that. There's nothing wrong with that, but people scared. Patient is scared, the doctor lagi scared. Yeah. Okay, that come to this one. This one, bipolar androgen therapy, BAT, meaning is interesting as it may say resensitize enzalutamide, restore study. What I read your comment. Okay, come with bipolar. Many years you go conference everywhere, off and on you get someone talking about that one, especially the American and all that. Meaning, after ADT long time, they suddenly they give a very high dose of testosterone to the patient one, sort of like suddenly you with a lot of testosterone, bomb you with testosterone, bomb the cell with testosterone, and after a while withdraw the testosterone again, trying to like recycling this and then induce the cell to be responsive to hormonal manipulation. So whether any effect or not, this restore study, if you Google, you type restore trial registry, you will find it one. It's in the American trial registry. Currently it is recruiting until I think it'll be ending next year, 2021. It is a single arm study. Yeah. So this is investigational one. When you look at it single arm, it is investigational study. It's not a phase 3 study. I think it's a phase 2 or something. Yeah. So that will give us some indication if upon completion of this restore study, it might give us an idea, but it's not conclusive one. So study got phase 1 study, phase 2 study, and phase 3 one, Normally, all the drug, reliable drug, the evidence that we all talk about, that Dr. Anthony Fauci talk about, all these are phase 3 one, phase 2 okay lah, but they cannot be conclusive one, because we have seen all some phase 2 study, wow, showing the drug, wow, so good, very promising, upcoming star, this kind of thing. At the end, you go to phase 3, tak pakai one, no use one. Because phase 3 is the definitive trial for the drug. So, because this is an interesting concept. So, at the moment, it's as phase 2 trial and all. So, consider investigational lah. Okay, let me see. Are there any method to prolong the time from hormone sensitive to castrate resistant? Or of course, this one, yes. There are ways to do that lah. At the moment, the hormone sensitive, they got all this like hormonal extra hormonal pathway inhibitor, albuterol, enzalutamide, and all that kind of thing. They can prolong the time for patient to develop castration resistant. Those are got evidence one. So patient with metastatic hormone sensitive, hormone naive, you can give this all the chemo, albuterol, enzalutamide. The new one, apalutamide, even apalutamide, that it will actually prolong the time to develop CRC. It will do that. So that is it. Okay, next one. Wait, I click next one. Okay. Salvage radiotherapy after radiotherapy failure. At what PSA to initiate radiotherapy? This first question. Okay. Second is ADT before RT a must? Or is there any exception? Okay, go to first one. What PSA to initiate RT, the salvage radiotherapy that we talked about earlier? If after surgery, the PSA come out, and after scanning the disease in the prostate, when do you start? Any PSA cutoff point? This one keep changing one. Old days, when we were training the time, they said 1.5, PSA 1.5. Then you drop to 1. Then you drop to 0.5. So basically, it's as soon as possible, as soon as possible, before they go beyond 1.5 or 2 or what. So the moment they reach about 0.5, you can give already, as soon as you can. So that is this one I asked Maniza also, the kind of answer, as soon as we can. Okay. Is ADT an absolute must? If ever possible, yes. If ever possible, yes. But if a patient cannot have cannot withstand the side effect of ADT or got severe heart problem, then maybe no. Generally we give ADT, but it's proven to be better than just giving radiotherapy alone. Radiotherapy plus ADT have better outcome. Okay, rising PSA after salvage radiotherapy. You go and shine it and it come up again, So with ADT, without ADT, what to do next, treatment at what level. This one is a bit more advanced already, more complex already. So surgery, then you have salvage radiotherapy, even salvage, then the PSA come up again. Again, the first step again is to look at where the cancer is. Is it still in the prostate or has it spread somewhere else? So that depends on that, whether to give ADT or not, or whether you can't find the disease, whether to wait it out or not. So that is a discussion between the doctor and the patient. This is a few steps ahead really, but it's a valid question. It happens to people, to patients. Basically, you face this one, do a scan, PSMA, PET, or whatsoever, to find out where the disease is, and then you treat accordingly. Okay. So 2 cases here. Patient A, Gleason 3+3, the best you can get. Extensive high volume bone mets, but currently on liquid.
Something mute.
Don't mute me lah. Mute me how I talk. I can hear me, can.
Yeah, now can.
No, I mean they're doing good intention to mute everyone, so there will be no noise.
There's a
done in good intention, Mana lagi balik tu. Okay, there we go. Here, if this one high volume metastatic disease on Lucrin 1 tablet abiraterone, which is the correct way to do it, that's the correct way. ADT plus abiraterone, known to be good one for high volume metastatic disease. Known is a fact. Got 2 randomized control phase 3 trial to prove that. Broke down the PSA very nicely. Yep. The question now come. Do you think RT to the prostate gland will improve progression-free survival, although it might not improve overall survival? Meaning, now it is so good already, why don't we do radiotherapy, shine the mothership, attack the mothership, kill the Death Star, see whether that will help or not. So the answer now is the no proven benefit, no proven benefit for high volume disease lah. If people do that, probably on a trial or investigational basis. The benefit for this radiotherapy to the prostate, to the mothership, it is with low volume disease, So you can shine the prostate gland, that you derive benefit. For high volume, there's at the moment no evidence, so you can spare yourself from radiotherapy. Yeah. Next patient. Next patient. Diagnosed 4 years ago, Gleason 9, PSA 8, RP is surgery surgery 3 years ago. So there's some information missing here, but it doesn't matter. So last year have 6 rounds of doxycycline. So something might happen after surgery. I think a disease come back, and all. So probably develop metastatic disease after surgery. Then have doxycycline, so which is the recommended treatment for metastatic disease. So PSA 4.8, then 6, then 8, July 11, meaning after the metastatic disease after surgery. Looks like it, there's missing information here, but we presume it is, probably it is. So metastatic disease, given chemotherapy come down, and now we slowly come back again. So now on Lucrin, Zomita, bone scan show mets, meaning the disease has progressed has progressed already after doxycycline. So this one is to discuss with the oncologist or urologist to go for second line. So meaning can be on abiraterone, enzalutamide, carboxycycline, can be on those medication. You can be on those medication. And just a note, Zomita is to strengthen the bone. Zomita or another brand is denosumab, Xgeva, to strengthen the bone, so won't get fracture. You can take that every 6 weeks or 3 months. But those patients on Zomita or the Xgeva, they must take calcium tablet and the vitamin D tablet. Quite important. Otherwise, the calcium will drop. Yeah. Okay, so what's the treatment option available? Which one recommend best way? Best way forward, this is the scan of the patient. So the best way forward is to consult the oncologist or a urologist. Basically, is to consider either be on abiraterone, enzalutamide, or carboxycycline, the next line. And normally, the patient will respond. It will respond. Yeah, good hope. Yeah. Next one. Okay, completed 6 cycle chemo. Waiting for Lucrin, another one. So, but didn't say what stage. You have 6 cycle or chemotherapy, most likely the patient have metastatic disease to start with. With no metastatic disease, nobody will start on chemotherapy. So, on Lucrin now, it's fine. Yeah, PSA dropped to 1.9. So the answer is, okay, abiraterone. Actually, if you're responding, I have chemo already, no need abiraterone, just wait just wait and observe. But you want to have, if the PSA come up, then second line will be abiraterone. Available in government hospital. I'm taking semi for last time, still taking metformin, aspirin, simvastatin. Safe to continue. Yeah, you can continue all those medicines. You can continue the aspirin, simvastatin, all can. pressure control, all good. So all this medicine you can continue, no problem. Yeah, can control. Whether available, of course, it's available in the most hospitals. Some will the charging system a bit different one. Some will have a lower price, some higher, some have quota or how many patients they will give per year and all. So you have to ask your oncologist to recommend which is the best way to go about that. This one I verified with Manisa already. Okay, this one. Can clarify if a patient can do chemo sensitivity testing prior to chemo to ascertain your benefit or not? Such of course it's available. America, any test you can do also one. But basically no definitive test lah. They can promote it maybe likely. We don't do one. We don't do one. I verify with Manisa also this one. But it is nice lah. They will advertise one. They will advertise. So good. This is so good. Okay. Anyway, does Prof recommend BAT is the bipolar one? He whack with high dose testosterone, then suddenly stop testosterone, then whack, then withdraw. A proven protocol. It's actually not a proven protocol lah. So there is this is a misnomer. This is not a correct term, but anyway, quite fun. In the US here, in Malaysia, especially for those who have no more option left, is there any doctor daring enough to do it, challenge, dare to do it or not? You dare. Your patient are willing to submit to this protocol. This one is not there or not there. This one is investigation. People do it. It's okay, So it's investigational. You want to do it, you can take the risk, It's up to the patient. Up to the patient, they want to kind of experiment on that. Or enroll in the trial, but difficult. The trial is in America. You can't enroll it for Malaysia. There's always daring person like this Mr. President. He said chloroquine, hydroxychloroquine, so good. He's very daring one. But at the end, it proven that it's no use. Fauci said no use. Okay. What is the difference between this one important? Quite important. Quite important. Something that I think the whole Malaysia can work towards that. This one is in the upstream one, very early on before talk about treatment, all that kind of thing. How to do a biopsy one. This is the upstream thing. It's an upstream thing. Okay, what's the difference between TRUST and TP biopsy of the prostate? Meaning to biopsy the prostate to see whether got cancer inside or not. TRUST meaning transrectal ultrasound, meaning the probe go to the rectum one. That is the standard one for so many years, until recently, the TP biopsy come about. That is transperineal, meaning through the skin one, through the skin below the scrotum. You to the skin, you puncture a needle there and take tissue from the prostate. So you don't go through the back passage, you don't go through the rectum. The diagnostic accuracy, of course, seems that the transperineal one, slightly better one, slightly better, because the access to the tissue most of the time is better one. And the good thing about the transperineal is that the risk of sepsis, having an infection, is lower one. That one is a fact. Transrectal, you go to the back passage, the back passage got bacteria and all that kind of thing, So the TP seems to be better one, So the pro for the TP transperineal is that, probably you can get access, accuracy will be better, and then cleaner, less infection. The drawback, it involves a very expensive setup one, the machine and all that kind of thing. And then most of the time are done under general anesthesia or some sedation one. So you must get the anesthetic involved one. Of course, there are people who say, I do under local anesthesia, whatever. Quite difficult one, Leg up there, and patients start to move and all that. Then the target, you very hard to aim at the target. It's like a moving target, kind of like an Olympic sport like that, flying target, you try to shoot, very difficult. So most of the time done under general anesthesia. So the cost is a big thing. Easily, you do proper costing, probably 10K at least one. Some charge 20K in some private hospital, depend on how the charging system So if basically in summary, so I think all should work towards a system that can offer transperineal biopsy. Yeah, but of course, with the cost consideration, general anesthesia, and its risk to be considered lah. So so cost here we addressed already. 10 to 20K. I think in most of the private center or what, because of the setup is expensive. Off and on, you get a lower price in some government or semi-government one, I think. Yeah, but it need to be sustainable lah. They probably won't give it totally free one. Sepsis rate, they got no data in Malaysia one, I think. Nobody have published on that. But from overseas data, very obvious one. The transperineal, the biopsy infection rate is super low one. So that's why in places like Melbourne and all that, who is under lockdown now, Melbourne now almost like 90% all done by transperineal. They seldom do the transrectal. Transrectal good point is that it's very cheap, relatively cheap one, and then very easy. No need general anesthesia one. You come biopsy, then you go home. I think most of the member here probably have a transrectal ultrasound. You go home the same day, get biopsy and go home on the same day. That's it. No need to stay in hospital lah, get COVID test that kind of thing. General anesthesia, come out anesthesia headache whatever. And then beside the anesthetic headache, when the bill come to your table, also you get headache. Look at the bill, also you get headache. Okay. So with that, I thank everyone. So factors, we must get the fact. Yeah, but fact is evolving now. So I will unshare my screen now. I think we have covered all the questions given. Thanks a lot. Let me see how I unshare my screen. I will unshare my stop share. I'll stop share first, so I hand back the